What if the sadness you feel right now is not who you are, but what you have been repeatedly consuming? What if the exhaustion, the fog, the quiet erosion of joy creeping into your midlife is not a personal failure, not a character flaw, and not even a primary depressive disorder, but a biochemical response to substances that have subtly reshaped your brain? In your 40s, 50s, or beyond, it is common to assume that low mood is simply part of aging, stress, or accumulated responsibility. Careers plateau, children leave home, parents age, bodies change. Yet beneath these visible transitions, something less obvious may be unfolding inside the neural circuitry that governs motivation, pleasure, and emotional regulation. Alcohol, prescription sedatives, stimulants, and even seemingly harmless nightly habits can alter dopamine and serotonin pathways in ways that closely mimic major depressive disorder. Fatigue sets in, sleep becomes fragmented, concentration weakens. Irritability sharpens. The world appears muted, as if someone turned down the saturation on your emotional life. And because the symptoms look and feel identical to depression, the default assumption is often psychiatric rather than pharmacologic. But neuroscience teaches us that the brain is exquisitely adaptive. It responds to repeated exposure with compensatory changes. When a substance artificially elevates or suppresses neurotransmitters, the brain recalibrates in the opposite direction to restore equilibrium. Over time, that recalibration becomes the new baseline. What once felt like relief becomes dependence, and what once produced pleasure becomes necessary simply to feel normal. This is not a moral weakness. It is homeostatic biology. In midlife, when stresses accumulate and resilience feels thinner, the temptation to self-medicate increases. A drink to unwind becomes two. A prescribed sleep aid becomes indispensable. A stimulant to power through long workdays becomes a cycle of surge and crash. Slowly, the nervous system shifts from balance to dysregulation. You may wake up tired despite sleeping. You may lose interest in activities that once energized you. You may interpret your emotional numbness as a personal decline rather than a neurochemical adaptation. The distinction matters profoundly, because treating a substance-induced mood disorder as primary depression can miss the root cause entirely. Antidepressants may blunt symptoms, but if the underlying exposure continues, the brain remains trapped in its compensatory loop. The philosophical question here is not simply clinical, it is existential. How much of your current mood reflects your authentic self, and how much reflects repeated chemical negotiation within your synapses? Midlife often forces reflection about identity, purpose, and vitality. Yet before concluding that you are broken or irrevocably changed, it is worth examining the invisible variables influencing your emotional landscape. The brain does not distinguish between stress relief and neuroadaptation. It responds predictably to input. If the input repeatedly pushes reward pathways beyond natural limits, the corrective mechanisms will push back. Understanding this mechanism is empowering. It reframes despair as a potentially reversible state rather than a fixed trait. It invites curiosity instead of shame. It encourages assessment rather than assumption. And it reminds you that biology, not weakness, may be driving symptoms that feel deeply personal. In midlife, clarity is not merely about insight. It is about accurate diagnosis. Because only when the true source of suffering is identified can meaningful, lasting recovery begin. As the story deepens, the most unsettling possibility emerges quietly. What if the very thing you believe is helping you cope is the engine driving your despair? In midlife, patterns are entrenched. Habits feel justified by decades of responsibility and sacrifice. A nightly drink appears civilized, even earned. A prescription for anxiety or insomnia feels medically sanctioned. A stimulant that sharpens productivity seems necessary in an increasingly competitive world. Yet the brain does not interpret these inputs through social narratives. It responds through neurochemistry. Alcohol suppresses central nervous system activity and artificially enhances inhibitory signaling, creating short-term calm while simultaneously disrupting serotonin balance and dampening natural dopamine production. Sedatives blunt emotional intensity, but in doing so, they can flatten effect and impair cognitive clarity. Stimulants increase dopamine rapidly, producing focus and drive, yet they often leave behind a neurochemical deficit that manifests as profound emotional crashes. Over time, the oscillation between elevation and depletion grows more extreme, and the baseline shifts downward. The result is a cluster of symptoms that mirrors major depressive disorder with striking precision: fatigue, low motivation, sleep disturbance, irritability, impaired concentration, and emotional numbness. The danger lies in the resemblance. A clinician pressed for time may identify the surface pattern and prescribe an antidepressant without fully evaluating substance exposure. The patient, relieved to have a name for the suffering, may accept the diagnosis without questioning the input shaping brain function. Meanwhile, the substances remain in place, and the brain continues adapting. This is where suspense intensifies, because the trajectory can move in two opposing directions. If the underlying driver is substance-induced and remains unaddressed, treatment outcomes often plateau. Symptoms may improve partially, but the core dysregulation persists. Frustration builds. Higher doses are considered. Additional medications are layered on. Complexity increases while clarity diminishes. Conversely, abruptly discontinuing substances or psychiatric medications without structured evaluation can destabilize neurotransmitter systems even further, intensifying anxiety, insomnia, or mood collapse. The middle ground, the disciplined path of careful assessment, requires patience and courage. It demands a comprehensive psychiatric and medical evaluation that examines timing, dosage, duration, and pattern of use. It requires laboratory data when appropriate, an honest accounting of alcohol intake, and a willingness to consider that relief-seeking behaviors may be contributing to distress. The philosophical dimension becomes unavoidable. Autonomy is not merely the freedom to choose substances, but the awareness of their cumulative impact. Midlife offers an opportunity for recalibration, yet recalibration can feel threatening because it exposes dependence that has been normalized. The brain, having adapted to repeated chemical surges or suppressions, resists sudden change. Cravings intensify. Mood dips temporarily. The individual may interpret this discomfort as confirmation of inherent depression rather than evidence of neuroadaptation reversing course. This is the critical juncture. Without accurate diagnosis, suffering can become chronic, not because it is untreatable, but because its origin remains misunderstood. Precision in evaluation transforms the narrative. It shifts the focus from labeling to investigating, from symptom suppression to root cause analysis. When substance exposure is identified as a primary contributor, gradual reduction under medical supervision allows neurotransmitter systems to recalibrate. Sleep architecture begins to normalize. Dopamine pathways regain sensitivity. Emotional range slowly returns. The suspense resolves not through dramatic revelation, but through disciplined clinical inquiry. What initially appeared to be an irreversible midlife decline may instead represent a reversible state of neurochemical imbalance shaped by cumulative exposure. Recognition of this possibility is not accusatory, it is liberating. It reframes treatment as strategic and individualized rather than reflexive. It underscores why structured evaluation before medication changes is not bureaucratic caution, but biological necessity. Only by distinguishing primary depression from substance-induced mood disorder can intervention become both effective and safe. Clarity in midlife requires a kind of courage that is both clinical and deeply personal, because once you understand that substances can sculpt your mood, you can no longer pretend that your emotional state exists in isolation from your daily choices. The work then becomes deliberate. It involves slowing down the impulse to immediately medicate symptoms and instead conducting a structured, comprehensive evaluation that respects the complexity of the human brain. This means examining timelines with precision, identifying when depressive symptoms first emerged, correlating them with changes in alcohol intake, prescription medications, or stimulant use, and distinguishing between episodic mood shifts and chemically reinforced patterns. It requires collaboration between patient and clinician, transparency about consumption, and patience during gradual adjustments. The brain is not a switch that flips overnight. It is an adaptive organ that recalibrates in response to consistent input. When input changes thoughtfully and systematically, adaptation can move in a restorative direction. This is where the philosophy of responsibility intersects with neuroscience. Responsibility does not imply blame, it implies agency. If chronic substance exposure has contributed to emotional flattening or despair, then modifying that exposure becomes a powerful intervention in itself. Gradual reduction under medical supervision allows inhibitory and excitatory systems to regain equilibrium. Dopamine receptors that have been downregulated by repeated surges begin to resensitize. Serotonergic pathways stabilize. Sleep architecture improves, and with it, cognitive clarity. Energy returns not as a manic spike, but as a steady baseline. Motivation reappears not as artificial urgency, but as intrinsic drive. The narrative shifts from helplessness to informed action. In this context, the work of Dr. Anna Lembke offers a valuable framework for understanding the balance between pleasure and pain in the brain. Her perspective underscores that every artificial elevation of reward carries a compensatory cost, and that sustainable well-being depends on respecting this balance rather than overwhelming it. Midlife, far from being a period of inevitable decline, can become a recalibration point where insight matures and habits evolve. Accurate diagnosis stands at the center of this transformation. Primary depressive disorder and substance-induced mood disorder may share outward features, but their trajectories diverge when treated correctly. A primary mood disorder may require carefully selected antidepressants, psychotherapy, and long-term management. A substance-induced condition demands reduction or elimination of the offending agent before additional pharmacologic layering. Confusing the two delays effective treatment and can entrench suffering that might otherwise resolve. The disciplined path forward emphasizes comprehensive psychiatric and medical assessment before making medication changes. It rejects abrupt discontinuation and rejects reflexive prescribing. It prioritizes evidence, pattern recognition, and individualized planning. When this process is honored, outcomes improve not through dramatic interventions, but through precision and patience. The emotional numbness that once felt permanent may gradually lift. Concentration may sharpen. Irritability may soften into resilience. Most importantly, self-perception transforms. Instead of seeing yourself as broken, you begin to recognize that your brain was responding predictably to repeated exposure. That recognition restores dignity and hope. Midlife then becomes not a verdict, but a turning point grounded in knowledge. Accurate diagnosis is not merely a technical requirement. It is the foundation of safe and effective intervention. If you are benefiting from our topics, please subscribe, like, and turn on the bell notification so you can see our new videos early.